So, dear colleague, I welcome you to the next session after the lunch break. So, maybe we'll wait 1 or 2 minutes until everybody has joined us. Okay, I see that the first speakers already, very well, already arrived. So again, welcome everybody to our next session. And this morning, we had a very interesting spectrum of different diagnostic fields. We had a lot of interesting case reports that teaches us a lot for our daily practice. We have investigated some real rare. We investigated a real rare lesion series of splenic lesions, and also we received an update of abnormalities on the duct systems of the pancreas, which I find very interesting. So, and our next session will be a travel around the world. We will start in India with Dr. Inara Abeer. We will go to Great Britain with Dr. Achana Bomana, and then we will change continents to Dr. Kirk Lin in Northern America. Then we go back to Russia with Dr. Inessa Telesnikova, and then we go again to another new continent. We go to Chile and listen to the presentation of Dr. Alvaro Ibarra. And the last 3 presentations we will receive from India, namely Dr. Manali Satisa and Dr. Arnav Kumar Roy Chuturi, and finally Dr. Abhishek Gupta. Well then, so I call upon our next speaker, Dr. Inara Abeer. Please go ahead.
Thank you so much, everybody, for letting me present my work on this platform. First of all, I would like to thank everybody. I'm Dr. Nara from India, which is a study of EGFR, and I hope I'm audible. Can I share my screen? Hello? Can I share my screen? Am I audible?
So we can hear you clear and loud.
Yeah. I would like to share my. Can I just share my screen? I think there's some problem. I'm not getting the permission for sharing my screen, my presentation. So I'm Dr. Nara. I'm a pathologist from India. I'm going to present my study of EGFR and HER2 new expression in the incidental gallbladder carcinoma, and we studied the clinical pathological parameters. It was an institutional experience from northern India. Why we chose to study about gallbladder carcinoma was that it's the sixth most common biliary tract carcinoma worldwide, and it is the third leading cause of death in northern India. And the Indo-Gangetic belt is the highest affected region for this cancer. The highest incidence worldwide is seen in Delhi with 21.5 cases per 100,000 cases. It is also associated with a poor prognosis or low survival. So we thought it is important to understand the various molecular carcinogenic mechanisms in the pathogenesis of this carcinoma, and if we could find out the use of a targeted therapy in this cancer. Uh,
Excuse me that I interrupt. Could you maybe try again to share the screen? We hear you clear and loud, which is cool, but we cannot see your screen.
yeah, I'll just try again.
Thank you very much. Oh, this looks very good.
Yeah, thank you so much. Uh, so, uh,
Yes,
what
very well.
I was saying was that why we took gallbladder carcinoma, why we took up the study, was that very limited studies in the Indian subcontinent have been done on this disease, and as we know that it is a disease of progression, and in the early stages, it is very rare to detect it. It is only incidentally detected, and if we thought if we could study some markers which could help us in giving us a prognostic help which could give a palliative treatment to the patients. So this is a world map, and the areas in in red show us the areas with highest incidence of gallbladder carcinoma all over the world. So coming to incidental gallbladder carcinoma, what it is defined as any GBC which is diagnosed during or after cholecystectomy, which is being done for a benign disease, is known as an incidental gallbladder carcinoma. And the incidence of incidental carcinoma worldwide, incidental gallbladder carcinoma worldwide, ranges from a zero point 0.2 to 2.1%, with females and elderly people seen more in the age group. So the Royal College of Pathology has given us a statement for histopathological examination of all the cholecystectomy specimens, irrespective of the normal gross and morphological features, as they can mostly be misleading. The aims and objectives of our study were to evaluate the role of EGFR and HER2 in incidental gallbladder carcinoma and to study their clinical pathological parameters in relation with the incidental gallbladder carcinoma. Our study was a descriptive cross-sectional study over a two-year period in which we took all cases of histopathologically proven gallbladder carcinoma, and we subtyped and studied the incidental carcinomas as a separate group. This was done in the Department of Pathology of Hamdard Institute of Medical Sciences and Research. The criteria for inclusions which we took were all adults more than 18 years of age, both male and female patients, and histopathologically confirmed cases. If any case had an associated malignancy or a prior treatment in form of surgery, radiotherapy, or a chemotherapy, we excluded those cases, and also cases which we could not prove histopathologically, but there was a clinical suspicion, we excluded those cases. All the cases were studied according to a well formed pro forma, and all the investigations and clinical examination and details were carefully noted in all the cases. We did a CA19-9 level for all the cases later on, which were found to be incidental. Initially in the study for all cholecystectomy specimens, we did not do a CA19-9 level, but cases which were incidentally proved, a CA19-9 level was followed up. We compared a before and after cholecystectomy diagnosis. A detailed grossing of all the cholecystectomy specimens was done. In case a tumor was found, it was studied, the location, configuration, dimension, a descriptive, a descriptive feature of the tumor the consistency, the color was studied. At any slides were studied. The samples in our department were received in 10% buffered formalin. They were not kept in formalin for more than 8 hours, HER2/neu and EGFR being very sensitive markers. So after an 8-hour immersion of the samples in formalin, they were grossed and studied. Staining was performed for EGFR and HER2/neu, and with all the slides, with all the batches, we put up a positive and a negative control. For EGFR, the positive control was skin, and for HER2/neu, we took a 3 plus known case of CA breast. The grading of IHC was done according to the CAP ASCO scoring protocol, which is followed for carcinoma breast as it is widely accepted. And in gallbladder carcinoma, all the studies which have been done have a variable number of grading systems which was used, and this was the only more reliable grading system which we could find. So a score of +2 and +3 was taken as a positive score, and all the cases were studied in duplication. So over this period of 2 years, we received 2,084 cholecystectomy specimens, and out of which 40 cases were of gallbladder carcinoma. Out of these 40 cases, we had 29 cases of incidental gallbladder carcinoma. So the incidence of gallbladder carcinoma in our institute, in our region, was found out to be 1.9%. And the incidental gallbladder carcinoma was about 1.3%. One consistent finding in our study was that all the cases were associated with gallstones. The mode of presentation of our cases of gallbladder carcinoma, 73% of the cases were incidental, which is quite high a number. We had a female preponderance in our study. Maximum number of cases were ranged from 41 to 60 years of age, and in the third decade we had the least number of cases, showing one patient. Family history in the second and third degree relative was present in 17% of the cases of incidental gallbladder carcinoma. Also, nausea was the only consistent symptom which was seen in 27 of the cases. Dyspepsia and right pain in the upper abdomen followed it. Patient presented with vomiting, and one specific pattern of vomiting which we saw, which was seen in 9 out of these 11 patients, was that they had multiple episodes, around 5 to 9 episodes of bilious vomiting, 5 days prior admission, and that was the reason of admission. No specific cachexia or cancer symptoms were seen in any of the patients which were admitted. Among the clinical diagnosis, it ranged from symptomatic cholelithiasis, which was the most common presenting symptom, and we had one patient presenting as empyema also. This is a gross photograph of one of our cases, which on grossing showed a focally thickened gallbladder wall. But on ultrasound and per-op, no abnormality was found. Only one thing in this case was that this was a difficult surgery. This is another gross photograph of one of the gallbladders. On cutting, we found a few papillary excrescences. We went back and tried to retrieve the ultrasound details, but nothing as such could be seen on the ultrasound. So the surgical procedure which was followed in the cholecystectomy cases, all the cholecystectomies currently are done by lab. Only 11 cases of our 2084 cases were open cholecystectomies because they were preoperatively diagnosed as gallbladder carcinoma. Among our incidental carcinoma, 7 cases had to be converted to open, and this was due to a difficult surgery and lot of adhesions. And all these patients were in the younger age group. The histopathological diagnosis ranged from a conventional adenocarcinoma, squamous cell carcinoma, and one case of adenocarcinoma with a xanthogranulomatous cholecystitis focus. So this is a microscopic picture of low power, which shows us a full thickness gallbladder. The wall was atrophic, which is shown by the red arrow, and the glands were reaching up to the muscle layer. This is another microphotograph of a squamous cell carcinoma of the gallbladder, which showed malignant glands in nests and sheets. This is the H&E picture, and the black arrow points towards the malignant squamous epithelial glands. This is another microphotograph, a high-power H&E microphotograph showing squamous cell carcinoma, which shows invasive nests and sheets of these atypical squamous cells. And there's a lot of dense lymphoplasmacytic infiltrate, which we could see. According to the stage, the gallbladder carcinomas are diagnosed as early and late carcinomas. T1A and T1B being the early gallbladder carcinomas. About 20 cases were in the early stage, and the rest of the cases were in the later stage of the gallbladder carcinoma. The purpose of early and late staging, dividing them into early and late staging, is that in early stage gallbladder carcinoma, surgery is said to be curative. Coming to the grade, there were only 4 cases which were poorly differentiated. The rest of the cases were equally divided as well and moderately differentiated cases. This is a microphotograph of a well differentiated adenocarcinoma. It's a H&E photograph scanner view showing these malignant glands which can be seen reaching up to the muscle layer. This is another H&E scanner low power view of a moderately differentiated adenocarcinoma, and it shows these malignant glands in cords and sheets. This is another micro photograph of adenocarcinoma, of a poorly differentiated adenocarcinoma, and these cells are seen in cords and they're singly lined. Coming to lymphovascular invasion, it was seen in about 7 cases. This is a microphotograph, high power, showing lymphovascular invasion. This is the perineural invasion was seen in 4 of the cases. This is a microphotograph, high power view, showing perineural invasion. Coming to our markers, EGFR was the first marker which we put on. EGFR and HER2/neu were subsequently put on in 2 different batches with a positive and negative control. So when we compared and checked the statistical significance of EGFR with all the parameters, clinical pathological parameters, it was found that the histopathological stage and grade were statistically significant. These are microphotographs. This is a microphotograph, high power view of EGFR showing no membranous staining. There is no staining in the glands. This is another microphotograph of EGFR showing a well differentiated adenocarcinoma of gallbladder. And this showed a scoring of 1 plus, which was incomplete and or barely perceptible staining, which was seen. This is another microphotograph showing a 2 plus positivity of EGFR. And 2 plus positivity was a positivity. It was either if it was weak or moderate in more than 10%, and if it was circumferential, it was taken as a 2 plus positivity. This is another micro photograph showing positivity for EGFR. This was a 3 plus positivity in our case. This is another micro photograph of a well differentiated adenocarcinoma showing a 3 plus EGFR positivity. This was a microphotograph of a moderately differentiated adenocarcinoma showing a 3 plus EGFR. This was poorly differentiated adenocarcinoma showing a 3 plus positivity of EGFR on low power. This is another microphotograph, a high power view of the same poorly differentiated adenocarcinoma showing a 3 plus positivity. Coming to histopathological stage, in the later stages, EGFR was seen positive in all the cases. In the early stages, in the early gallbladder carcinoma, in the T1B stage, 5 cases were negative, and in T1A, 4 cases were negative for EGFR. So, EGFR showed a positive correlation which was statistically significant. When we come to the grade, all poorly differentiated EGFR were positive or poorly differentiated gallbladder carcinomas were positive for EGFR. Lymphovascular invasion and perineural invasion did not show any statistical significance, although all the cases in which lymphovascular and perineural invasion was present had a positive EGFR, but even the cases where it was absent, most of the cases had a positivity for EGFR. Coming to HER2/neu, which is the other marker which we studied, HER2/neu only showed a statistical significance with the grade. So this is a high power microphotograph. This is a low power microphotograph of a well differentiated adenocarcinoma of the gallbladder, showing a 2+ positivity for HER2/neu. This is another microphotograph of a moderately differentiated adenocarcinoma. It showed a 2+ positivity. This is another microphotograph of a well differentiated adenocarcinoma of the gallbladder, showing a 3+ positivity for HER2/neu on scanner on low power. This is a high power microphotograph showing a very nice circumferential positivity. It was seen in more than 10% of the glands, and most of the HER2/neu staining came out to be really very well in our study. So this is so it showed that all poorly differentiated carcinomas were negative for HER2, but the well differentiated carcinomas and moderately differentiated carcinomas were predominantly positive for HER2/neu expression. On grade, poorly differentiated carcinomas showed a loss of HER2/neu expression. Another consistent finding which we saw in our HER2 case was this. This is the intratumoral heterogeneity which was seen in our cases. This was a well differentiated case of adenocarcinoma of gallbladder, and it showed us intratumoral heterogeneity. That means one part of the case showed us a 1+ positivity, but the other section showed us a positivity of 3+. And intratumoral heterogeneity is well established in breast carcinoma as well and is associated with a very bad and poor prognosis. Coming to the discussion, so EGFR immunoexpression has been studied in gallbladder carcinoma, and it has shown a variability of 100% immunostaining to as less as 11%. In our study, the immunoexpression was found out to be 72.5% for EGFR, and for HER2/neu expression, the studies which have been done, they have ranged HER2/neu expression to a highest of about 90% in carcinoma in situ, with as low as 9% to 6% in some of the studies. Our studies showed a HER2/neu immunoexpression of 32.5% in the cases which we had. So I would like to conclude with the fact that there is a very possible good scope of targeted therapy in carcinoma of gallbladder, which is promising results with regard to immunoexpression of EGFR. HER2/neu expression was far more in better differentiated tumors and the early stage tumors. And this suggests a very good and positive possible role of HER2/neu as an early event in carcinogenesis of gallbladder. Also, both these markers, HER2/neu and EGFR, respectively can be used as a predictive and prognostic markers. And further rationale to explore the anti-HER2 and anti-EGFR therapy in gallbladder carcinoma can be explored. Our study was a limited study, and it is one of the stepping zones. It is one study which can act as a stepping zone for other large-scale studies to identify the existence of patients who could benefit from targeted therapy, particularly in advanced gallbladder carcinoma. Also, our study was resource limited as we could not perform FISH on our cases. We did not have any external funding, which was there. There are a few recommendations which we would like to give on the basis of our study is that GBC being the most common biliary tract carcinoma worldwide, being associated with a poor prognosis, it should be dealt differently. More studies should be conducted, mostly in the northern part of the country, In rural health, there can be a health policy and decision-making changes for people with just symptomatic cholelithiasis being treated in a different way so that we can elevate our health system. And there is also a necessity for an archetype marker for GBC that will help us diagnose and prognosticate the disease and choose our modality of treatment accordingly. So, opportunity to make a headway in basic understanding of biology of gallbladder carcinoma and management paradigm is really necessary. And the most important thing which we would like to recommend was that accurate molecular characterization of the tumor is necessary so that we can enroll the patients in clinical trials so as to define which patient group would benefit from targeted therapy. These are the references. Thank you so much. Thank you so much.
Thank you so much for your comprehensive analysis of your collective of gallbladder cancers. Nice pictures and very thorough immunohistochemically analysis. So, and now I would like to call up our next speaker. This is Dr. Achana Bomana. Let's see, well, she's online, which is cool. And she would like to tell us something about D240 protoplane marker to distinguish primary skin and axial tumors from adenocarcinomas metastatic to the skin. Okay, we cannot hear you right now. You are still muted. Oh, well, they should be all right. Well, you are not muted, but well, at least I cannot hear you, unfortunately.